as Dr. Francis just said, and by the way, this is also a poster presentation at AHA, so put the slides together last minute. But as Dr. Francis just said, we took a look at cardiac arrest after cardiac surgery, specifically looking at the long-term outcomes of those patients. And a tiny bit of background information that's relevant. No surprise, but cardiac arrest is a very grave complication or feared complication after cardiac surgery. Literature reports that the incidence of this is between 0.7 and 5.2%, and a case fatality rate anywhere between 30 and 80%. We'll get to our data in just a second. Perioperative MI is often reported as the cause of most cardiac arrest, but other things like tamponade or graft or prosthesis malfunction, ventricular arrhythmias, aortic tears, things like that are also reported to be causes of cardiac arrest. And the short-term mortality is very high due to things like renal failure, sepsis, anoxic brain injury. But prior to our study, we didn't really find anything that reported the long-term outcome of those patients who survived cardiac arrest and survived to hospital discharge. So as you can imagine, this was our objective, was basically just to investigate the long-term outcomes of those who survived cardiac arrest after cardiac surgery. And to do this, similar to Ryan's research project, we examined the cardiac surgery database that's kept at the Minneapolis VA. And this included 6,979 consecutive patients going all the way from 1991 through December of 2014. And of this, we found 182 cardiac arrests. So thankfully not too many. And the important things to know about this database are that they collected info on the demographics, pre-op imaging, clinical values, lab values, and then the post-op outcomes. And the post-op mortality was recorded at 30 days, 1 year, and then long-term. And our patient population, no big surprise for the VA. And I have those with a little bit tough to see. But this is the patients who don't have cardiac arrest, so 6,797 patients, and those who do, 182. And the population was mostly males in both groups. But as you can see, just starting here to look down the column of patients who had cardiac arrest, they are a little bit sicker with a New York Heart Association class 3 or 4 heart failure and with a lower ejection fraction than their colleagues. And they also had a little bit more complicated surgery, meaning some of them had had prior cardiac surgeries, more of them had a non-elective surgery, they had a little bit longer cardiopulmonary bypass time, and more of them needed a pre-op intra-aortic balloon pump. So they were probably sicker going into a more complicated surgery. More of our results. The majority of cardiac arrests occurred within the first 3 days, so this was our median, and 51% of cardiac arrests occurred within the first 3 days. There was one that had already lasted into day 30 of that hospitalization, but that was an outlier. The majority happened up front, and many were, as you can see, many were on the very same day as their surgery. Some additional results. This was the type of cardiac surgery in patients with and without cardiac arrest. So CABG right here was the majority of patients, and this was CABG without any other associated procedure. And they actually had sort of the lower or lowest incidence of cardiac arrest in comparison to those who had CABG plus some other surgery or some other surgery. And this other category down here includes things like ASC or VSC closures, an anomalous coronary artery repair, or something structurally related, I guess. Some additional results. So here is kind of the meat of our data. So at 1 year of follow-up, 24 patients, at one year of follow-up, 24 patients had already died, and that was after this in-hospital incidence of death that was 51%. So 51% died right away. Another 24% died within the very first year, and that's in comparison to those who don't have cardiac arrest. So this was significant. And then getting at the long-term follow-up down here, our average follow-up was about 7.5 years for these patients, and the long-term mortality rate for those who had cardiac arrest versus those who didn't was 81% versus 34%, and that was also statistically significant. When we adjusted, however, for age, sex, and the year that the surgery was performed, having an in-hospital cardiac arrest was associated with a 4.7 times higher incidence of long-term mortality in the whole cohort. And then if you look at a 30-day outcome there, the incidence is the risk is 2 times higher for long-term mortality. And if you go all the way out to the long-term follow-up, the mortality is 1.3 times higher, which was not statistically significant, but trended towards significance. You can see these curves do still deviate, but not statistically significant. In multivariate analysis, we were trying to look for some predictors that would help figure out which patients are going to do worse if they survive to hospital discharge. And not too much of a surprise, also discharging to home was much better than being discharged to a facility. And if you left the hospital with abnormal kidney function, that was also a sign of a worse outcome in the long run. And then the last piece of data that I just wanted to share was we were sort of curious in CPRS, which is our computer system at the VA, came into effect in 2001. And only those patients after 2001, we were able to extract a little bit more data about the details of their cardiac arrest. So we have a little bit more interesting data about just 105 patients that occurred after 2001. And the interesting thing here is, I guess, the non-fatal cardiac arrest versus fatal cardiac arrest. Much more of them were VT or VF, and they all got defibrillation. And it's not too much of a surprise that those are the patients who end up doing better in the long run. The last interesting piece of information was that 11 patients who survived cardiac arrest discharged from the hospital with an ICD during that same hospitalization. And none of those patients ever needed their ICD. Only one had an inappropriate shock, but all the rest never had an appropriate shock during follow-up periods. So our conclusions is that cardiac arrest is not good after cardiac surgery. Long-term mortality, in addition to short-term mortality, long-term mortality still remains high, even if you've discharged alive from the hospital. And potentially discharge disposition and renal dysfunction could be used as predictors of those people who will experience long-term mortality. I think that's it. And I will just acknowledge Dr. Audubag, who spends countless hours with me, Dr. Vakil, and Shadi, and Dr. Ravindran for letting me go to AHA. Yeah. Can you go through the slides from the beginning? Yeah. So one of the things that should come out for an aspect is that it should follow a very logical fashion. There should be no surprises. So if you're presenting data that somebody wasn't expecting to see in the beginning, it should be part of the message. So, okay. Nice slide. Go forward. Okay. So background, I think overall is very nice. You should have a hypothesis slide where it simply states what you're trying to do. And it should happen after the background. The background should lead us to the idea of why you're doing it. What is not out there, why are you challenging the existing body of literature, what more are you trying to learn? Okay. Rather than putting the objective and message together. And then the message should line up with that it only needs to be a simple idea, but for you it's going to be exploratory analysis, that you're going to separate the cardiac arrest from non-cardiac arrest, you're going to do a proportional hazard analysis, you can do a multivariate analysis, and then maybe the last one, which you didn't mention until near the end, is that in those patients for the last 10 years in that very detail, you're going to do a deep, in-depth analysis to find out about it. So patient population, I think you did a nice job here. Once again, I'm just saying this, I'm not sure if the University of Minnesota is referring to you, but if you're stepping back from here, I'm not the right level, but black line versus these, like black line green is going to be hard to see. And somebody who's going to look at this, the most important thing they're going to want to know is what's the difference between the left and the right column. If they don't know who's got the cardiac arrest and who doesn't, they don't know how to interpret anything. Because so one thing that would be very nice for this is to show a cumulative incidence. So on the right axis, go from 0 to 100%, so it's a different axis, and show a curve that's going to go something like this. So people get an idea of
where it's what you're going to see on a curve like this, which makes sense. If there's people with cardiac arrest, there's a big jump in the beginning, and then it comes back and
Mm-hmm. Yeah.
But as you discussed this, I have a hard time to, first I wasn't expecting the right slide to come to left, because first I thought you had expanded it. But the impression I got when I looked at the right, not seeing any two values, it really wasn't that much of a difference. But you had stated initially something like a four-fold increase. So I'm not sure if I can see what you were saying from that slide, or I'm misunderstanding.
Yeah, I agree.
Okay.
This is a critical slide.
Mm-hmm.
It was a little confusing. It looks like actually once you survive 30 days, the rate of death is about the same, because the slopes are pretty similar. And I don't know if you made that point clearly or not. So.
Okay.
And
I'll work on that.
I think one of the important things is that if I'm looking at this, if I had a cardiac arrest in the hospital and I'm alive in the hospital, I'm particularly interested in whether or not after I go out, I'm going to be alive. I'm assuming that that blue line is in hospital. It may be important to identify, or some people would take the graph and explode it and show this is the point afterwards. This is probably where that blue line becomes curvilinear of what's happening to the people. It's just an important thing because, you know, if you're out, if you don't make it out of the hospital, then it doesn't matter. Right? But for those people who make it out of the hospital,
yeah. Okay.
This one, I think it was more like the chicken and the egg thing. So I would say that the reason that people went to we have a nursing home, and I'm not saying that conversation, but if they're dead at the end of the angioplasty and borderline on the vent, I'm not going to send them home to be with them. So this is kind of, I don't think the information goes correct, kind of this mix. I do think it's really important, and you mentioned it, and I heard you say that I couldn't function, but I think the thing that's very important to learn from your data is what are the predictors or what identifies that people will alive with success. So you should have applied from your logistic regression or somewhere tabulated so that people know, oh, for people like cardiac, maybe it was the incident less than 30 days, maybe it's the day at beach in the hospital. What were the things that you have them that allowed you to identify who's alive and not alive? Because that's really what's going to lead you.
Okay.
I'm just trying to give you some ideas of
that's really helpful.
What to do and to keep it clean. But in particular, people lose interest in the living relationship. You know, the first thing they do is they want to see. I like how you actually identified instead of asking questions. You actually made a statement and it's a very unique way of doing it. And I'm not sure if that was your method. That's fantastic. But the next 2 or 3 slides are very interesting. So, and I think some of the other fellows are in the same thing with the background. You don't want to spend too much time on your background because this is really your presentation, not a review of the literature. The background should really be kind of synopsis. It's to highlight maybe 2 or 3 points leading to why you're doing your work. And it's particularly important on the following slide about your hypothesis and then for your methods to be very clean. And theoretically, each one of those goals for your methods is going to lead to a slide which is an aspect of your results, limitations, and treatment. Setting them up.
Thank you. You can ask me later.
Other questions, Kurt?
How is your survival in these people compared to anybody else, like somebody who's coded not having cardiac surgery? Same survival.
I mean, there's the cause of cardiac arrest is so wide. It's a little bit hard to make that comparison. At least our data did match what's previously been reported for the incidence and the mortality, in-hospital mortality of cardiac arrest. But it's a little bit hard to answer that question, I guess, because the circumstances of the surgery are a lot different than, you know, anyone else who codes in the hospital.
Okay, I'd like to.
Are you working on paper?
Yeah, under review.
I'd like to thank all 3 presenters. All 3 did a very good job, and we'll see you down in Orlando. Thanks.